Okay, I think we'll go ahead and get started. Folks can continue trickling in here, but just in the sake of time, we'll go ahead and get started. Thank you all for being here for the Department of Medicine Grand Rounds. We have a special guest speaker today, Dr. Rachel Issaka. She's going to be discussing transforming the colorectal cancer care pathway from screening to survival. I'm going to ask that everybody writes questions and comments in the chat, and we will take some time at the end to answer those questions. But thank you so much to Dr. Issaka for being here today. She is a gastroenterologist, associate professor, and the Kathryn Surace-Smith Endowed Chair in Health Equity Research at the Fred Hutch Cancer Center in the University of Washington. She's also the director of the Fred Hutch and UW Medicine Population Health Colorectal Cancer Screening Program. Her research focuses on improving outcomes across the colorectal cancer care continuum, including equitable access to screening and follow-up of non-invasive screening tests. Her work has been funded by the National Institute of Health, the Centers for Medicare and Medicaid Services, and the American College of Gastroenterology. Dr. Issaka has contributed to national medical practice guidelines for the Centers for Disease Control, the National Comprehensive Cancer Care Network, and the National Colorectal Roundtable. She completed her gastroenterology fellowship at the University of California, San Francisco, where she also earned a master's in clinical research. She completed her internal medicine residency at Northwestern University's Feinberg School of Medicine, where she also served as chief resident and obtained her medical degree from the University of Michigan Medical School. So please welcome Dr. Rachel Issaka.
Thank you very much for that kind introduction, and thank you for the invitation to share some of our work. I'll go ahead and get started. Let's see, hopefully I can move these slides. Nope. We will stop sharing again. Let's see if we can get these things to cooperate. Are you all seeing the slides move?
I'm just seeing the first slide. They're not moving.
Are you seeing the slides move now?
There we go. Yep.
In the right view still?
Yes.
Okay, excellent. Okay, so just by way of my financial disclosures that are up listed there. I can see my desktop is going to misbehave today. All right, so this is an outline of what I'll be discussing today. So first, talking about the impact of colorectal cancer, talking about some of our research and quality improvement initiatives across the health system, including our population health colon cancer screening program, a focus that we have on follow-up of abnormal screening tests, as well as some work that we are doing in surveillance after treatment. And then I'll conclude with some next steps. So colon cancer has been in the news a lot recently, but I think it's important for everybody to understand the burden of this disease. And so in the United States, right now it is the second leading cause of cancer deaths, with an estimated 53,000 people who will die from this disease this year, and that those estimates have been quite persistent over a period of time. Just last month, we found that it is now the #1 cause of cancer deaths in men and women who are under the age of 50. And despite this being one of the most preventable cancers, 40% of people who are between the ages of 45 and 75, which are the ages that are recommended to be screened, have never been screened. And here I'm showing you a picture of T-Mobile Park just to show you a sense of the impact of this disease. So T-Mobile Park at its peak level of fullness seats approximately 48,000 individuals. So imagine this park being completely at capacity and people overflowing into the streets. This is really the degree of deaths that occur from colon cancer every year. So there are multiple failures that can happen across the cancer care continuum when it comes to colorectal cancer that leads to ultimately poor outcomes amongst individuals. And so when we think about this continuum, there are opportunities at the very beginning to reduce an individual's risk, to hopefully avoid development of disease, but if they do develop disease, to detect it early, and then hopefully treat them and allow them to enter a period of survivorship. And so basically, along this entire continuum, there are failures that can occur, whether it's in prevention, detection, treatment, or in surveillance. And so our team has studies across this care continuum, probably with the exception of treatment, but one never knows, so we might get into that space in the future. And today I'm going to share some of the work that we're doing really related to development, early detection, and again, in surveillance. And so our lab's mission is to really make colorectal cancer prevention, screening, and follow-up care equitable, high quality, and accessible to everyone, to improve health and to eliminate disparities. And that's really the backbone of what fuels the questions we ask and the work that we do. And we execute this mission using a variety of tools, including research, quality improvement, community engagement, and trying to influence guidelines and health policy. So I'll touch on some of these throughout the talk. And so let's talk about the Population Health Colorectal Cancer Screening Program. So this was really the thing that brought me to this institution. Back in 2017, when I was recruited here, there was a real interest and desire in improving and understanding colon cancer screening across the UW Medicine health system. And at the time, there hadn't yet been a metric that had been defined across the health system. And so that was a lot of the early work that I did and working with Dr. Flum and others in that and Source to, really using some CMMS funds to help describe different metrics across the health system. And so we defined this metric of colon cancer screening as the percent of adults who were 50 to 75 years of age who had had an appropriate screening test. And the numerator would be people who had received at least one colorectal cancer screening test. The denominator would be all individuals who were between the ages of 50 and 75 who had had a primary care encounter in the past 3 years. And this was important because you have to remember that UW Medicine is an open healthcare system, and so we have people that come and go. And again, this was before the change in the guidance that reduced the age to begin screening to 45. And we excluded individuals based on if they had advanced comorbidities, if they had had a total colectomy, history of colorectal cancer, other documented exclusions that we could pull from the electronic health record. And so in going through that exercise, what we learned was that there were approximately 84,000 individuals across our health system that would be considered eligible and were in panels, meaning that they had been assigned a primary care doctor, were receiving care within the past 3 years. And so we believe them to be truly our patients based on as much as we could define. And of those 84,000 people, only about 55% were up to date with colon cancer screening. And the goal then and the goal now has always been 80%, but this was really the point at which we started. And so using a combination of strategies, and here I'm showing you the data of screening across the medium to small groups that our healthcare system is broken into. And so we used a combination of strategies, which included piloting Mailed Fit, increasing awareness of this disease with direct patient education and communication, and then also communicating the importance of colon cancer screening with our primary care partners. And in this early demonstration work, we were able to increase colon cancer screening across our health system from 55% to 71%. And then COVID-19 happened, and we saw this across, the United States, but we also saw declines here within our own health system as well. And so that 71% that we were achieving now slowly started to decline, and we found ourselves at about 68% in 2021. Now, keep in mind that the goal of colon cancer is to stop or catch the evolution of cancer early. And so in an ideal world, you want to catch people when they have cancer before it has spread outside of the gastrointestinal tract. We know that when colon cancer is found still within the wall of the gastrointestinal lining, that at 5 years, survival is 90% or greater. Unfortunately, only about 40% of people are diagnosed with colon cancer at this stage. And we know that once colon cancer has spread through the mucosal lining of the gastrointestinal tract, that 5-year survival is only about 10 to 13%. So, fueled with all of this information, we approached the health systems of Fred Hutch as well as UW Medicine, and we asked, can we create something that is sustainable, that acknowledges the fact that we are now in the midst of a pandemic where screening colonoscopies are considered non-elective procedures and therefore being deferred. And we know based on our pilot work that mailing these tests to individuals' homes can work to improve colon cancer screening. We were able to get buy-in from both institutions to get funding for this work. And really, the mission that we had ahead of us was to improve overall colon cancer screening rates across, the health system for all UW Medicine patients, and to ensure participation was occurring equitably. And then we also, expected that the program would improve patient care quality, increase healthcare equity, and drive additional payer contracts across our health system. And so here's the team. Myself and Ken Makinsoto, who is the Assistant Director for Primary Care and Population Health, Ari Bell Brown, who is a project program manager who has been with me throughout the period of this work, Dr. Vicki Fang, who's the Medical Director of Primary Care and Population Health. We have a dedicated program manager for the CRC screening program. And I would say probably the most important people here are Amy Peck and Jerry Wood, who are the navigators who support this work. So the program components include this quality improvement, which I'll share a little bit more about, research on what the quality improvement initiatives are, and then using that to inform changes within the program. We do a lot of efforts around community awareness of what colorectal cancer is and educational events, and then also trying to inform and influence healthcare policy here in the state of Washington, as well as nationally. So how does this work? This is specifically related to the quality improvement part of work. And so what we do is that we identify patients who are not up to date with colon cancer screening, and then we kind of work backwards and we say, who are the patients who are at most risk of not either coming in for a primary care visit, not coming in for a laboratory visit, or any other reason why they would interact with the healthcare system. And once we sort of identify those patients, we then they receive a mailed letter, usually some prompts ahead of time as well, letting them know that we found that they're no longer up to date. We are planning to send them this kit in the mail that they can use to complete colon cancer screening, and they have opportunities to let us know if the information that we're working with is not accurate. Once they complete it, it's all analyzed within our central laboratory here at Harborview. And then the panel navigator will work with patients if they have not returned the test in a certain amount of time to understand if they're having any challenges that they can assist with. And then if people have an abnormal result, the navigator will also work with them to help them get an appointment for a colonoscopy. And so here I'm showing you just uh, some charts that demonstrate what we see as far as fit return. And this is looking at data from 23 and 24. 24 is in orange. And so you can see that when we track this information, we can see the proportion of people who are completing the fit test. And, in 24, we ended up with about 40% of people completing it. And you might say, well, how does that compare with other places? And so here I'm showing you some data from around the country that is looking at mailed fit programs of other large healthcare systems. And you can see that we match and exceed a lot of the programs that are happening nationally. So here I'm showing you what has happened. This is, just kind of skipping over a lot of details, but just showing you what has happened to colon cancer screening across our health system since we started this work. Now, this denominator of 72, or this proportion of 62%, is lower than what I initially showed you, because remember that now we start screening at 45. And so once we added those 45-year-olds, the denominator went up, the numerator stayed the same, and so we just had a lower proportion of people completing CRC screening. But what we can see is that over, the 4 years of this program, that CRC screening across our health system has improved from 62% to now 73% amongst 45 to 75-year-olds. And when we break this down by health system, we can see that certainly, we had lower initial rates across Harborview, but that those numbers are going up as well. And we certainly still have more work to do to bring screening rates to the same level across all the clinical sites within our healthcare system. So now I'm going to tell you some of the work that has, supported some of the research that has supported the quality improvement initiatives. And so here, this is work that was led by Sam Simpson, was a medical student here and is now an internal medicine resident at Stanford. And Sam wanted to, help us ask the question, well, who is actually completing their fit once it gets mailed to them? And can we incorporate that information into further outreach? And so what he did using our data was that he found that patients who were living with a partner were patients who were living without a partner were less likely to complete their fit compared to those who were living with a partner. Patients with Medicaid insurance were less likely to complete screening once they received outreach. And that also patients who had completed screening before, however, were almost, 50% more likely to complete their fit once it was mailed to them compared to those who had never screened before. We also found that if patients had been seen by primary care within the past 12 months, that they were the most likely population to complete fit. And then we looked at something called area deprivation index, which is a composite measure of social risk amongst individuals, and basically found that the higher social risk individuals had, the less likely they were to complete a fit once it was mailed to them. Here I'm showing you CRC screening by rate, by race. And again, keep in mind that the goal nationally is 80%. But what we see here is that, we are getting pretty close, right, for white identifying individuals. For other groups, and for Asian identifying individuals, but for other groups, we do lag behind, even though promisingly we are seeing improvements in colon cancer screening across all groups. So again, not there yet, getting close, but still some work to do. Next, I'm going to highlight a project by Marina Hanna, who is one of the current GI fellows. And Marina, wanted to ask this question of, well, how are our 45 to 49-year-olds doing when it comes to screening, especially now that the USPSTF has changed the age to begin colon cancer screening. And so we looked at our data going back again to 2021, which was when sort of the baseline for when the CRC screening program began. And what we found was that when we look at 45 to 49-year-olds, they have had steady increases in their colon cancer screening rates. These numbers are showing 2024 data where we were around 52% for the 45 to 49-year-olds. The 25 data shows that we're now at 56%. Nationally, keep in mind the average CRC screening for 45 to 49-year-olds is 30%. And so we are exceeding national metrics right now. Again, 80% is the goal for everybody. What we can see is that for those who are 65 to 75, that we're already hitting that 80% mark. And one of the questions that we wanted to ask of this particular data was, when you introduce screening for 45 to 49-year-olds, does that displace older individuals from getting screening? Because ultimately, these resources are limited in some ways. And what we found was that was not the case. That, again, older individuals are continuing to get screened in addition to younger people. We also found that in our health system, younger people actually use colonoscopy a little bit more than they use FIT, which is a little different than other national data that suggests that younger people prefer non-invasive screening strategies. And so we have other work evaluating preferences within younger people in our healthcare system. So modeling some data, we said, okay, well, how long will it take us to get to that 80% goal? And just based on the kind of 3% incremental increase we've been seeing per year since the CRC screening program started, it looks like we would reach that 80% goal by about 2029, which is about 8 years. There is one health system in the US that has reached that 80% goal, and that is the Kaiser healthcare system. And it took them about 20 years to get there. And so I think, again, this is really promising and encouraging for the work that we're doing to, not lose sight of that ultimate goal because these efforts do take time. And what happened in Kaiser when they did reach that 80% goal? You can see that they were able to reach that for all races and ethnicity, and they do this primarily through a mailed fit outreach strategy as well. But I would say more importantly that they were able to close mortality gaps between white individuals and Black individuals, as well as other racial ethnic minorities. So whereas before, when their program started in 2002, where there were these big gaps and differences in deaths, now those gaps have been closed. And so again, very encouraging for the work that we're doing. And just to sort of show you where we fit in with the state and what the state is doing, UW-Medicine has been acknowledged 2 years in a row for having some of the highest screening rates amongst commercially insured individuals. And this is just data that is pulled by the Washington Health Alliance, where the national kind of benchmarks were around 73% for commercially insured individuals, and our rates were 86% for commercially insured individuals. And so looking ahead at this work, we have, some focused initiatives to, again, bring up screening rates for all individuals because we see those differences by race and ethnicity. We have interventions that are ongoing to improve follow-up of abnormal fecal immunochemical tests, as well as expansion to other sites across the state, really, because we get asked quite frequently, well, you're doing this work within UW-Medicine, but what about the patients that don't receive care here, and how can we also gain in on some of this work? And so we're working with a community health site to help them develop their own blueprint for how they might implement such a program to improve screening rates in their health system. So now let's talk about follow-up of abnormal fecal immunochemical tests, because honestly, all tests that are not colonoscopy are considered two-step screening strategies, meaning that if somebody has an abnormal result, they must get a colonoscopy in order for that screening process to be complete. So this is a systematic review that our team conducted looking at what has been reported related to follow-up of abnormal fecal immunochemical tests in the country. And what you can see that it doesn't matter if you use FIT, multi-target DNA, FOBT, if you look at health systems like federally qualified health centers, safety net health centers, VAs, or integrated health systems, that across the board, here again, where the goal is 80%, that very few places hit that 80% follow-up goal. And in fact, within our own health system, when we started this analysis, we were around 41% follow-up within 1 year. What we also know is that follow-up is very important, and that in fact, if you don't complete follow-up within 9 to 12 months of an abnormal fecal immunochemical test, and this is based on several studies, that the risk of advanced stage cancer increases. And amongst the population that completes FIT, if you look at folks 10 years out who never complete a follow-up colonoscopy, that they are twice as likely to die from colon cancer as those who completed their follow-up colonoscopy. And in some of our own work where we asked providers and patients about barriers to follow-up, one of the things that came up quite often was lack of transportation. And so this was repeated by patients and as well as providers, that the lack of a ride to complete a colonoscopy was often the deterrent for people who had consciously made a decision to complete CRC screening using a FIT. We in fact had one of our participants tell us that they had, overheard a patient saying that they just found a random person on the street and that they paid them $40 to be their person that would, say yes to giving them a ride home. And so from our perspective, we thought, well, rideshare exists, in other capacities. Can this be harnessed to improve follow-up for colon cancer screening specifically? So when we think about rideshare platforms, the infrastructure is already present. I think many of us are used to or have used rideshare in the past. There is the technology that's also already present. There's already a payment structure that's built, and there is public safety and trust that's inherent in the programs as well. However, endoscopy units almost universally prohibit the use of rideshare after sedation, at least when we started this work. So there were policies that specifically restricted the use of any rideshare after sedation. There were a lot of concerns about risk, liability, and patient safety, and concerns from the legal perspective. And if we're being honest, medical practice, just really moves at a slow pace. And so things take a long time to change. Well, we hypothesized that rideshare non-emergency medical transportation platforms were a potentially scalable and cost-effective strategy to increase colon cancer colonoscopy completion in people who had abnormal fecal immunochemical tests. And so the first aim was that we wanted to identify the barriers and facilitators, as well as the process recommendations that would be required to implement this into practices where people receive sedation. And we wanted to start within our safety net health system because that was where we saw some of the lowest follow-up colonoscopy completion rates. And then our second aim was to then pilot this in that setting to see how it would work in real world. And so this work was led by Ari, who is my research program manager. And over a 1 year period, we conducted about 22 different interviews with about 34 different individuals. And these ranged from people all the way from the state healthcare authority to patients, anesthesiologists, nurse managers, you name them, we probably spoke with them. And of course, our lawyers, because, again, of the risk and liability concerns. We use storyboards as a way to quickly expedite these meetings, meaning that we would have images instead of text of what we were trying to communicate. And that allowed us to get on the same page with people who might not necessarily have been in medicine. And then we had a nominal group technique with 5 critical stakeholders to finalize the rideshare workflow. And in doing all that, we were able to finalize a contract between our health system, UW Medicine, and Lyft Healthcare. And the way the platform works, so it's Lyft Concierge, and it's essentially this white glove service in which somebody can call the ride for the patient. The patient themselves don't need to have a smartphone. And we've been able to fund all of this work through either grant or philanthropic support. And the way the current process works is that patients, when they are referred to GI for a colonoscopy, need to demonstrate that they have a ride home. And so at that point, if the patient says that they don't have a ride home, then the patient care coordinator refers those patients to our research team. We then go through an informed consent process with them. If they say yes, we communicate that back to the team. On the day of their procedure, the nurse manager, once they're completely recovered, will call for the ride on their behalf. They, the patient, are not able to change the final destination. Somebody from the team accompanies them into the vehicle. Our team can track patients throughout the platform, and we interviewed the first 200 patients or so to understand if there were any safety concerns or liability concerns, and none occurred. So after that, we basically stopped interviewing people, but I'll share some pilot data from that work. And so since this program started, we've completed over 450 rides for patients, initially limited only to those with abnormal fecal and chemical tests. But there was such high demand for this for patients who needed, let's say, an EGD for esophageal variceal screening, that we allowed patients who needed endoscopy for any indication and sedation without a ride to use this intervention. The average ride costs about $40. Median duration has been around 4.7 miles with about 18 minutes total. And as I mentioned, we interviewed the first 200 patients. We have not had any safety incidents reported to date. And in fact, we have a lot of patients who want to be spokespeople for this program. So here, just showing you some quotes from discharge nurses who are saying that it's very flexible. They just go online, they put in the address, the driver would be downstairs. It was quick, easy to use. This is a quote from a participant that said they didn't really have any friends or family, and they would have had to, they didn't have anybody they know, they would have had to pay somebody to pick them up. And then this is from a primary care provider who was saying that it wouldn't have been possible for their patient to get their procedure without this program. And then once they did get it done, that they had more than 20 polyps found on their first colonoscopy. So we sort of ultimately, we acknowledge that while we've been fortunate to have funding for this work by grants and philanthropy, thinking through sustainability and how can we make sure that this program really persists for years here and elsewhere. And I think one way we can do that is to think about how can we inform funding decisions at the CMS level. And so wanted to model this out to see what this would look like. And so the objectives here were to determine the effectiveness and the cost effectiveness of providing rideshare to patients who had had abnormal fit results using a microsimulation model. And again, the long-term goal is to inform a potential Centers for Medicare Medicaid Services coverage decision for similar rideshare interventions. And so when we think about colorectal cancer, we use the CRC spin model, which models each individual with a natural history, presuming that you start with no precursor lesions, that you eventually develop one or more precursor lesions, that those precursor lesions can develop into cancer that's initially asymptomatic. Eventually, you might develop symptoms, and then you might die from colon cancer or you might die from something else. And so you can imagine that in a scenario where here we're assuming everybody's using annual fit for their CRC screening. And for each person, their screening is modeled based on their outcomes, based on their true state. And so you could have somebody who does a FIT every year and it's always negative, and so they never need a follow-up colonoscopy. But then you have somebody who does a FIT every year and then eventually it turns positive and they have to get a follow-up colonoscopy. And so some are going to get it and some may not. And so I'm just going to walk you through some of what these scenarios might look like. So here we have simulated populations. These are four single age cohorts of 45, 55, 65, and 70-year-olds. And again, we assume that they're adherent to their annual FIT, and we assume that 35% at baseline would complete a follow-up colonoscopy without any intervention. And this was based on the data from when we started the population health outreach. And then we apply an intervention that's either a $40 ride or a $100 ride. Again, I told you that our average ride cost is $40, but we wanted to assume, what if we were in a more expensive market? What impact would that have? And then we looked at varied colonoscopy completion rates from 40%, so again, just a 5% bump from baseline, all the way up to 100%. And all of this was done across an individual's lifetime horizon. And the things we wanted to look at were effectiveness, so the number of colon cancer cases per 1,000 people screened, deaths from colon cancer per 1,000 people screened, and then life years gained per 1,000 people screened. And then from the cost effectiveness perspective, we wanted to look at what were the lifetime costs associated with improved completion of colonoscopy after an abnormal FIT at an average ride cost of $40 or $100. And so here I'm showing you a population of 45-year-olds. We apply a $40 ride, and let's say we have a 15% improvement, so 35 to 50% complete their follow-up colonoscopy. What this would do is that it would reduce colon cancer cases by 14%. It would reduce deaths by 18%. It would result in about 13.4 life years gained per 1,000 people screened, and would result in about $204,000 saved over an individual's lifetime and only cost about $8,500 per 1,000 people screened. Now let's take another scenario. Again, adults 45 years old. We're also going to apply a $40 ride, but now let's improve colonoscopy completion by 35%. So we now would reduce colon cancer cases by 26%, so up from 14%. Deaths would reduce by 33%, up from 18%, would result in 25 life years gained, and would result in about $356,000 in savings over a lifetime, costing about $17,000 per 1,000 people screened. So again, now we go from about $8,500 per 1,000 people screened to about $17,000 per 1,000 people screened, but you're saving more money over an individual's lifetime. I'm going to show you one more. So here we have 45-year-olds, but now let's say the ride costs $100 instead of $40, and the same 35% improvement in follow-up colonoscopy. So we don't change the number of cases, we don't change the number of CRC deaths, we don't influence the life years gained. What does happen is that the savings goes down by about 20,000. So we go from 356,000 saved to now it's only 330,000 saved, and it costs more. So it costs, instead of 17,000, it's now going to cost 43,000. And this, pattern persists regardless of age. And so we see, remarkable kind of decrease in cancer deaths. We see cases prevented always going up regardless of age. And again, the pattern holds true regardless of cost. And this is really because, and we actually modeled how much this could cost and still be beneficial. And it could cost up to $498 per ride and still be cost savings, because increasing colonoscopy completion in this group with abnormal FIT results, it really is the combined effect of detecting precancerous lesions and detecting colon cancer at an early stage. Cancer at the end of the day costs money. And so if you're able to prevent cancer from occurring, then it remains a cost-saving intervention. So just to kind of give a summary of what we've talked about so far, we identified transportation as a barrier. We engaged stakeholders to adapt an existing product. We piloted it and demonstrated safety, and then we modeled it to show cost effectiveness. And so you might be asking, well, what about clinical efficacy? And so we now have our grant to test this in a randomized controlled trial to determine if patients who get this, in addition to other tools, ultimately do a better job at following up after an abnormal fit compared to those who do not. And this is a quote from one of the participants who says, and it works, there are just people like me who kind of fall between the cracks. We don't have any kind of support system, and having the rideshare made a difference. And so this is a high-level overview of our R grant. This is just demonstrating all of the preliminary work that went into this, and the randomized controlled trial will randomize patients who are in a safety net health system, again, because this is where the need is greatest, to getting a multi-level intervention that includes navigation and rideshare, versus our usual care now, which is the population health colon cancer screening program. We'll look at outcomes of effectiveness, so looking at follow-up colonoscopy completion, as well as implementation of the intervention, acceptability, and how much it costs to implement in such a healthcare system. And our hypothesis is that this bundle of interventions will lead to higher follow-up colonoscopy completion rate compared to the standard of care. So I'm going to wrap up by talking very quickly about surveillance after colorectal cancer treatment, because I did make that promise and I want to honor that. So in the US, we know that there are about 1.5 million colon cancer survivors. And unfortunately, about 40% of them experience recurrent disease within 3 years of surgical resection. And this is thought to be due to lack of surveillance. So we know that surveillance care is multimodal and complex. It requires CEA, it requires cross-sectional imaging, as well as endoscopy. So to the point of endoscopy specifically, we wanted to see, well, how are we doing in our state for people who've been diagnosed and treated for colon cancer? And this is work that was led by Talia, who is now a HEMONC fellow at Utah. And the question she wanted to assess was, among stage 1 through 3 colon cancer patients in Washington state, how many people had completed a 1 year post-surgical surveillance colonoscopy? And then we also wanted to determine patient clinical and geographical factors that were associated with surveillance completion. So this is a retrospective study that we did using the Washington State Cancer Registry data that was linked to administrative claims data. And I was very surprised to learn that only about 56% of eligible Washington state patients completed a surveillance colonoscopy after they had been treated. And this is amongst a cohort of about 4,500 individuals. And we actually followed folks out to about 18 months to try to account for delays in submission of claims data. And unfortunately, that number, that 56%, held true. What we found was that older individuals, people with higher comorbidities and higher stage cancer, as well as those with Medicare insurance and those living without a partner, had decreased likelihood of surveillance adherence. And then we also looked at clinics, because we were like, is there something at the clinic level that could be influencing this? And found that across clinics, there was a lot of variation. So anywhere from 37 to 88% were actually adherent to that 1 year surveillance colonoscopy. But that there were some clinics that had a lower than expected 1 year surveillance colonoscopy completion based on the patient mix, based on these variables that we had identified, that they didn't have many of these patients and should have had a higher surveillance rate. And so next, I worked with Natasha, who is now faculty, and Pranusha, who's one of your chief residents, wanting to understand what are the, sort of the clinician and the patient-identified determinants that influence follow-up after cancer treatment. And so here they used qualitative study designs to talk to patients and providers across our region. And this is the study population. So we use the Value in Cancer Care Network, which is an academic community consortium of about 217 medical oncologists and 14 health systems. And they recruited 14 clinical providers and 19 colon cancer survivors. And what they found from the clinician side of things were the barriers included fragmented care, because patients were coming all across the state, coming to our cancer center for treatment. A lot of workplace pressures, so just not enough time, which I think many in the audience can relate to. Long wait times to get patients in for procedures, as well as geographical barriers. But the facilitators that seemed to help were when patients received reminders and education, were routinely interacting with the healthcare system, and then when there were settings where patient primary care and specialty care were integrated. And so this is a quote from one of the interviewees that said that if patients hear it from their doctors or APPs, then they know that it's important. And then from the patient side of things, patient worry about colonoscopy results was the biggest barrier that patients identified. Difficulty with the bowel prep, as well as lack of communication from the clinic. And patients identified facilitators as the clinics assisting with appointments, reassurance about their colonoscopy results, as well as provider influence and education. And a quote here was from a patient. They said, as long as it's on the calendar, I'm getting an email or a text message, I'm not going to miss it. So even if it's, 12 months from now, just schedule it and I'll come. So what's the summary here? Again, 56% of eligible colon cancer survivors in the state were completing their 1-year surveillance colonoscopy. Um, and in the literature, completion of other surveillance care like labs and imaging is often lower. In our qualitative analysis, we found that patient education, reminders, and scheduling assistance facilitated surveillance care completion. And again, from our perspective, we thought there are practical and scalable interventions that could improve surveillance care for these survivors. And so we landed on, well, what about navigation, which is really the role and activities of people to help them overcome barriers and facilitate access to quality care, which we know works in screening and now has uh, um, a refundable code for it for cancer patients. And then looking at patient education through a tool that was developed by a colleague at the University of Michigan, which is called Current Together After Cancer. This is an interactive web tool that delivers educational information to patients after cancer treatment. And so we wrote a pilot award to test these two interventions together as well as simultaneously. And we put together a team. We received that funding and currently have that study ongoing right now, where we have 3 sites where patients are either randomized to navigation, randomized to the web tool, or they receive both. And we're looking at surveillance colonoscopy, CEA, as well as radiographic test completion in these groups. So, in conclusion, there's a significant need for interventions to improve colon cancer care across the continuum, starting from prevention, early detection, all the way through surveillance. Our work has shown that population-based programs can improve screening, but require additional supports to make sure that people with abnormal results get the recommended follow-up care. I also showed you some work that showed that rideshare that's provided by a healthcare system is safe and address transportation barriers, but ultimately we know that multi-level interventions are likely needed to improve health across the board, especially as it pertains to colon cancer and to eliminate the disparities that we see in colon cancer care. So want to acknowledge the many funding sources that support this work, the amazing people I have the opportunity to collaborate with, as well as my more immediate team. So thank you so much for, again, the invitation and your attention, and I look forward to the discussion.
Thank you so much. It looks like there's a question in the chat. Anna Wald says, beautiful presentation and really important data. She's curious how 80% became the goal for this screening cascade and comments that percentage seems low.
Mm. So 80% for follow-up or 80% for screening? I can talk about both. Let me, since I can't see you, Anna. Okay, so for the screening, 80% was the goal set by the National Colorectal Cancer Roundtable. This was set years ago, and I think they acknowledged that amongst the population, there will always be some for whom screening is not right because screening should be done if you suspect that it will prolong somebody's life by more than 10 years. And so there are people who will have less than 10 years of life expectancy. And also, screening for some might confer more harm than benefit. And so that was where that 80% goal came from. And initially, it was 80% by 2018. For a long time, I remember hearing that. And then 2018 came and left. And I told you here in the US that 40% of people still are not up to date with screening. And so 80% has now become the persistent goal. When it comes to follow up for abnormal fit, I think it was again that same acknowledgement that some people will get fit tests erroneously. And so somebody might get a fit and then, it turns out they maybe shouldn't have. Or maybe somebody gets a fit and then they have a more terminal diagnosis, like a cancer diagnosis or end-stage kidney disease. And those diagnoses then become more important. And so again, acknowledging, that not everybody's either appropriate or life circumstances change. And so 80% became the goal there, which again is still aspirational as we have not yet reached it.
Great, thank you. I was curious, and I may have missed this, but you had mentioned that folks that are younger who are completing their fit tests have a higher likelihood to go on to get a colonoscopy. Is there, is that, no?
No, I was talking about screening within our health system. So, national data shows that young people, 45 to 49, have a preference for non-invasive screening strategies. So, FIT, multi-target stool DNA, potentially blood that's coming online. And I didn't talk about blood tests today. We have some work in that as well. But what our data within the UW Medicine Health System shows is that there is a slight preference for screening by colonoscopy for young people than there is FIT. So, that flips the picture that we see nationally.
Thank you. Let's see. Erica Johnlin is asking, how long does it take to schedule a colonoscopy after an abnormal fit?
That depends on where you are. So, during COVID, and again, when colon cancer screening was deemed to be a, non-urgent procedure, we made the argument that people with abnormal fit results actually should be prioritized, right? Because we know that this population has a higher risk of getting colon cancer compared to somebody who's just coming in for their initial colon cancer screening test. And so, ideally we should be, and again, I showed you that data that 9 to 12 months is when we start to see people have more advanced stage cancers if they delay that long. So ideally, we should be getting these people in within before 9 months, certainly but before 12 months. There is a HEDIS measure that is currently in process, meaning that right now HEDIS just gives health institutions credit if people complete colon cancer screening. So if you get a fit, you get a check mark, great. It does not follow people who have abnormal results. There is a measure that will be tested that is going to ask what proportion of people that get a non-invasive test get a follow-up. And with that will be a timeline of 6 months. And really the idea being that if we can get people in sooner, then we can hopefully catch people kind of trickling between that 6 to 12 month period. So I can tell you within our health system, we're generally able to get these people in within 90 days, again, acknowledging that they're a higher risk population, but this will differ from health systems across the country.
Dr. Ken Steinberg says, thank you. This is a wonderful Grand Rounds presentation, an important demonstration of the importance of health services research. Do you envision studying the role of AI in helping the health system get screening and follow-up testing?
Yeah, I mean, I think AI is everywhere and certainly, could augment some of the work that we do. When I think about patient identification and helping streamline records. So right now, our patient navigator does an excellent job of coalescing data from different healthcare systems using Care Everywhere, scanned media, and all of those tools. So can we use AI to make sure that we have the most complete information on individuals to inform their screening journey? I think that would be, a really wonderful way to use this data. And I think that there are also opportunities to use AI to, assess data after the fact. So, for example, in the patients who get screened and then have polyps and then need follow-up, how can we use AI to better study image data to make sure that everybody's getting the right surveillance at the right time? So I think there are several opportunities, and if there are folks on this call who have that expertise and want to partner, I welcome, please reach out and I'd love to talk to you. How does your program compare to others in the US? For example, the VA. Carol, do you mind maybe elaborating in what specific way? I'm not sure if Carol is still with us. Oh, screening rates. So overall, colon cancer screening within our health system right now, I think we're probably a hair better than the VA nationally. Um, as far as fit return rates, I think we're probably neck and neck. Um, I know that there are projects going on across the VA. It's not completely apples to apples because not all VA health systems use a mailed fit approach. Jason Dominitz, who's the national director of the VA's GI care, is really working hard to make this uniform across all VAs. So I think probably for VAs that are using mailed fit approaches, we're doing, just as well, maybe a touch better.
And please keep continuing asking questions in the chat. I have a question that it's kind of a big question. It can probably be a talk in amongst itself. But you mentioned that colon cancer has been in the news a lot of young folks passing away from this disease. And so I'm just curious, why do you think that is? Like what is the current kind of research telling us about why so many younger people are getting colon cancer?
Yeah, I think that is the million-dollar question that everybody's asking, and that is a separate talk that I give on
Yeah.
early
Yeah.
onset colon cancer. But just briefly, what we can tell is that, from 1960s until now, that there are more young people dying from colon cancer than their predecessors. And so if you're simply looking from a time frame perspective, then you start to ask, well, what happened in 1960s till present that wasn't, there before? And some things that people have looked at are environmental exposures. One thing that we certainly see is a trend in obesity, and the trend in obesity tends to mirror very much the rates of deaths that we're seeing in young people, and this is true not just in the US but nationally. There's some recent data that shows alcohol consumption is strongly linked with early onset colon cancer and specifically rectal cancers in younger people. So, begging the question, does alcohol consumption behave differently in tissues that are in the rectum compared to the rest of the colon? And that data is really interesting because it basically shows that people who drink two or more alcoholic beverages per day when they're young have a higher risk of colon cancer than those who drink less than that. Um, and then the other work that's been coming out is around ultra processed foods. And so foods that, really don't mirror the ways in which they grew out of the earth, right? That people who eat large amounts of those foods have a higher risk of developing tubular adenomas. And we know that tubular adenomas are the polyps that are most likely to progress and become colon cancers. And so I think, there's still a lot of work and questions around younger people. But what I tell my young people for now, and because we saw a lot of this of like symptom dismissal or the idea that, colon cancer could not happen in young people and so would have, bright red blood intermittently and that would get dismissed. So for my young people, I say don't dismiss those symptoms. Make sure that you are seeing a healthcare provider and, being referred to a gastroenterologist. Let's talk to see if a FLEX-Sig or colonoscopy makes sense, but let's evaluate that. Iron deficiency anemia is something that precedes a lot of early onset colon cancer. And so for young people that have it, refer them to gastroenterology and let's do a colonoscopy and upper endoscopy, make sure there's nothing there. I tell my young people to make sure they know their family history. Lynch syndrome, which, often we think about uterine and colon, but for some people might only first show up as uterine cancers in their families, and they might not know that that's present and that they need to be screened earlier. And so to get that history so we can, start them being screened earlier if necessary. And then, to try and avoid alcohol as much as they can, or at least reduce its use to try and reduce the use intake of ultra processed foods as well.
Great. Thank you so much. I know that's a huge question, and like you said, to talk in amongst itself. Last call for questions. Otherwise, we can go ahead and wrap up. Well, thank you so much, Dr. Issaka. That was a wonderful talk. I really
Yeah,
appreciate
thanks.
it.
Thanks for having me. Take care.
Lots of thank yous.
Mhm.
Oh, wait, we do have another question.
Oh, and Kim, our internal and family medicine provider sharing the information on early onset colorectal cancers. I don't know. That might be a better question for some of the internal medicine and family med providers on the
I know,
call.
at least during residency, in my primary care clinic, I was.
Hmm.
Um, was a big topic of conversation. Yeah.
What are you sharing with them?
Um, I mean, essentially just updating folks on the changes in the US PSTF
Yeah,
guidelines and
yeah,
how, and especially talking about if they have any family history of those, the cancers that you mentioned, that they may even
yeah,
need screening earlier on.
yeah,
Make sure that they're also, diligent about, symptoms, if they're experiencing symptoms that we would just go straight to a colonoscopy
yeah,
instead of, doing like a fit test.
yeah, yeah. And I mean, I think, for those who aren't aware, UW Medicine just recently opened a new endoscopy center up in Northgate. So, endoscopy capacity is increasing across our health system as well. We have Harborview, we have Eastside, we have Montlake, we have Hutch. So there are many sites where patients can get, colonoscopy, and that hopefully should not be a deterrent for people getting the care that they need.
hmm Yeah, my primary care clinic was at the VA, and we had a really hard time getting folks colonoscopies, and so a lot of the time they would have to do the community care
Mm,
referrals because the
to
GI,
go elsewhere.
yeah, was
Mm.
very backed up there. But they were still able to get them fairly quickly in
Could
the.
they come to UW, one of the UW Medicine sites?
You know, that is a good question. I don't think maybe, but I don't think any of my patients ended up going to UW,
I
but
see.
I'm not sure. I don't know if anyone knows, they should pop that in the chat.
Well, thank
Okay, well,
you.
thank you so much.
Take care.
Thank you all for coming.